Since I'm the only speaker, they told me it was fine for me to go ahead and give a 2-hour lecture on the history of phenotyping. I hope you don't mind. That's what we're doing today. I'm kidding. What I do want to talk about is I'll talk a little bit about what I mean by clinical phenotyping. It's a term that I think gets thrown around a lot here at the Institute, and some people may or may not know what it means. I'll talk about it. I'll talk about what it is and then its relevance to public health, since I'm do public health informatics in a school of public health. And then I'll talk to you about some of the research we've been doing to use phenotypes to assess population health. So we'll talk about claims data. We'll talk about some sexually transmitted infections, and I promise I won't show any images. And then our current work that's underway now relates to maternal and child health. So we're going to kind of run the gamut, if you will, of public health this morning into the afternoon. And then I'll talk a little bit about our future directions, where we're going with our public health informatics program. To get started, I want to recognize that what I'm talking about, even though I'm the PI on many of everything that I'm going to talk about today, the work is highly collaborative, right? We're in an era of team science, and so my work would not get done without the help of the incredible staff, first and foremost at the Regenstrief Institute. Second of all, critical partnerships that I have with folks at the Marion County Public Health Department, as well as the Centers for Disease Control and Prevention in Atlanta. So very much what we do is collaborative with scientists at CDC and Marion County Public Health Department, working hand in hand with myself, colleagues at School of Public Health, and of course the staff here. So let me begin by talking about what a clinical phenotype is. The word phenotype comes from the Greek, meaning to show a type. It's used to classify things. So in genetics, which is really where phenotyping became most well known in the scientific community, it's really talking about or typing or just characterizing the physical presentation of a given trait. So you can think of sort of, blue eyes versus brown eyes as a way of phenotyping someone versus the genetic code that gives you the blue eyes or the green eyes or what have you. So in medicine, phenotype refers to the presentation of a disease. So when we want to try to find, for example, or search in our data core wants to go searching for all the individuals with hypertension, we first have to describe what is hypertension, how is hypertension manifested in the population, and how will it be represented in the data so that we can go and search for it and find it and bring back that cohort of hypertensive patients. So let me give you an example from public health and the work that I do on sexually transmitted infections. So if we look at chlamydia, right, clinical diagnosis is driven by a number of things. So it's usually patients present with certain symptoms. So they may have things like pelvic inflammatory disease or problems with urination. That is a first signal to the clinician that they are thinking, this is probably a case of chlamydia. However, what we do is we then follow that up by ordering a lab test and confirming the diagnosis through the laboratory. So we then screen them, patients screen positive via lab culture, antibody, or PCR test, and then we will say, now now we have a case of chlamydia, right? So it's not just the physical presentation, and it's not just the lab result. The two really often work hand in hand to confirm a case of chlamydia. And that leads in public health for CDC and CSTE, which is the Council of State and Territorial Epidemiologists, to come up with strict case definitions for a case. So in the case of chlamydia, it's a positive lab test or a clinical diagnosis via an international classification of disease code. All right. So ICD 9 version 9 was used until October of 2015 in the United States. And then in October, we switched to ICD version 10. Just for those of you who are internationally minded, version 11 is out and Europe is already using it. So we're always behind in the United States, which another fun fact that I often like to tell my students is, does anyone remember when ICD 10 was officially mandated for use in the United States? What year? What? 2015 is when we had to finally cut over, but when was it first passed by Congress that thou shalt move to ICD-10? Does anyone remember? 2009? 1996, that's right. It took 20 years for us actually to implement what Congress passed. It was passed in the original HIPAA law. Required, most of HIPAA is about administrative simplification, and in that law it said thou shalt move to ICD-10, and look how long it took us to get there. How long did it take? Right, probably, yeah, New Zealand probably moved very quickly. Yeah, other countries move a little bit more nimbly than we do. So I'm going to talk a lot today about some of our work to sort of validate phenotypes, particularly with respect to ICD codes, which is why I bring it up. And one of the ICD codes have, and claims data in general, has always been popular amongst health services researchers, but it's increasingly popular amongst public health, particularly at the CDC level. So a major source of data for the CDC is what was originally called Truven Market Scan, now purchased by IBM, but they use market scan data to do a lot of their studies and analyses at the CDC, in part because when a clinician in Indianapolis reports a case of chlamydia to the Marion County Public Health Department, they do so and they identify the person and they give them the details on the clinical case, and then the case management information gets entered at the local level and fed up to the state health department, but CDC is not allowed to have identifiable information. So once it gets to CDC, all the information about the case is stripped off except for a few key elements. So if they really want to get a handle on the prevalence of a disease in the population, not only with STIs, but also with chronic conditions for which there's no mandatory reporting, CDC has to turn to large data sets like Market Scan. Here's a couple examples of how they used it. Recently at CDC, one was to look at Market Scan to identify Lyme disease to assess prevalence across the population. And in particular, this study looked at 13 sort of high incidence states to get a sense for whether Lyme disease was present. And what they found is they could find more cases in Market Scan for those high prevalent states than what they get from the state health departments that report to CDC. So CDC says, aha, we can find new cases, right? And then same thing in the STI division at the bottom. They used Market Scan to identify those who had both an STI and who tested positive for HIV. And they found that HIV screening rates amongst those with STIs was lower than what CDC had found through some of their survey work. So a lot of the work that CDC does, a lot of our public health data sources are either based on self-reported survey data or from sort of large mining of claims repositories like Market Scan. And CDC really thinks that these are great. However, as we know at Regenstrief Institute, ICD-based reporting is not perfect. In this study that we did a number of years ago here at the Institute, we saw where 4 different institutions within the IMPC had different lag times for when they reported an ICD code to the state health departments, right? So some places are reporting it within 24 to 48 hours. Some of them aren't reporting all of the cases until 2 weeks later. So there's issues with timeliness, there's issues with completeness, and there's some concerns about validity. So what we need to do, always in research we do this, but also in public health practice, is we need to institute good quality control practices so that we can understand the limitations of the data when we're trying to use them to answer a particular question. So the first thing that our team did in concert with our friends at CDC is that we did an existing, we looked in the literature. What do we know about the validity of ICD code, using ICD codes to find STI cases? We were focused on chlamydia, gonorrhea, and syphilis, which are the most prevalent ones reported in the STI if you kind of ignore HIV. So out of about 2,000 articles that we found from a very robust search, only 2 of them really had any kind of information on the validity of ICD codes for chlamydia, gonorrhea, or syphilis. All right, so there really isn't much known. Both articles that we did found really focused on PID. They were trying to validate whether an ICD code for PID was was actually reporting a true case of PID. And so they didn't really independently assess the validity of all of the ICD codes that you could potentially use for chlamydia, gonorrhea, or syphilis independently. When they did do it in the context of PID, the positive predictive value was very, very broad, right, from 18% to 79%. So this really shows that there's a lack of evidence around this. So what the CDC wanted us to do to follow up on our review of the literature is to conduct a study. So we turn to what we call the STI registry, which is something that a project that got underway a number of years ago, first with Wanzhou 2, and then Bill Tierney was the director of the program, and then Bill passed it off to me. So we've been kind of working in this space now for over a decade with CDC to use the IMPC as a starting point to better understand the prevalence of disease and outcomes for individuals who have an STI. What I've done with the project since taking it over is I've also built relationships with the Marion County Health Department so we can integrate their birth registry data into there, as well as the morbidity files that come from the public health clinic, the Bellflower Clinic, and the regional program that collects cases on all STIs that are reported to public health. So integrating those data into with IMPC, and then creating de-identified data sets that, as Andrea will tell you, are quite large now, and putting those in the high performance computing environment at IU in such a way that we can have IU and Regenstrief and CDC personnel access them. Because remember, CDC is not allowed to have access to identifiable information. So if we gather the data, we link it all, and then we create de-identified data sets, we can then use those to spur different research projects. So the project that we did was we wanted to look specifically at validating ICD-10 codes for STIs, given the dearth of evidence in the literature. So this was a retrospective cohort that we pulled together from the IMPC, starting with the cutover to ICD-10 in October of 2015, all the way through the end of the first year, which was 2016. And then we looked at all patients aged 13 to 44, which are the ages at which we look at women being sexually active, typically, plus, or at least where they could, right, but that's not totally true, but that's where we look primarily for around maternal child health. Those are the ages that we mostly think of. And so we looked at that same age range, which is also guided by the CDC criteria for case definitions. And then we looked at ICD-10 diagnosis of chlamydia, gonorrhea, or syphilis, or the ICD diagnosis of unspecified STD. And then we also looked for all those who have received laboratory testing for at least one of the three diseases. So if we pull this together, we would have in the combined cohort people who are truly negative because they got tested and tested negative. We would have people who received positive tests only and no ICD code. We would have ICD codes with no testing. So we wanted to get that whole sort of data set so we could appropriately calculate sensitivity, specificity, positive predictive value, and negative predictive value. So our question was, are the ICD-10 codes accurate for the three STIs? And then we confirmed diagnosis using chart reviews, with our outcomes being primarily sensitivity, specificity, PPV, and NPV. This is a visualization of our design. So we started at the left with the total disease cohort with all these people mixed in based on any kind of way that they got a diagnosis of STI. And then we said, did you get an ICD code? Yes or no? And we split those two into groups. And then for the ICD code, was there really truly positive? Yes or no? And then for laboratory testing only, is it really a true case? Yes or no? The chart reviewers were procured through DataCore, and then we developed mostly Yinling Ho, who is not here. He's right in the middle of his qualifying exams for PhD. Hopefully he's still hanging in there, right, Ashley? Yeah, okay, good. So he can't be here, but he developed a very extensive protocol, which we then captured the data using REDCap. They reviewed plus and minus 30 days from the ICD diagnosis. The protocol was mostly extensive because CDC was interested in those cases that were positive for syphilis, what was the exact typing or staging of syphilis that was occurring. And then for the unspecified STD cases, we had to look at any kind of positive diagnosis because it could be potentially positive for one of the three results of interest as a true positive, and false negatives were those who had positive laboratory tests but never received an ICD code, because our frame of reference was, is the ICD code valid for them to use in something like Market Scan. All right, so the complete cohort by disease, we had about 82,000 chlamydia cases, 79,000 gonorrhea, 31,000, and a lot of these are negative tests. So don't think that that's our incidence in Indianapolis. And then, although I will say we are number 3 in the country for gonorrhea, and then unspecified STD was 603. About half came from diagnosis in the outpatient setting, another 43% for emergency, and so a tiny bit from inpatient. So if we look at we look here at true positive, false negative, true negative, and then our calculations based on those 4 numbers for sensitivity, specificity, positive predictive value, and negative predictive value, you can see that specificity is fairly high with ICD, but the sensitivity is pretty low. It's not capturing everything because there are a lot of positive lab tests that never get an ICD-9 or 10, in this case ICD-10 code associated with it, and so that affects our positive predictive value, especially for unspecified STDs, which there were quite a few of those. If we look specifically at ICD results, about 82% of the time, if it had an ICD code for chlamydia, it had a positive lab result, equally around 80% for gonorrhea, lower for syphilis. So a lot of times people are getting ICD codes for syphilis, but there's no laboratory confirmatory testing that would tell us that they are indeed positive for the disease. So to dig into this further, we wanted to look at the time frame of when the ICD-10 diagnosis was occurring with respect to the laboratory testing. So if we look at the A64, which is the unspecified STD, in the black, those are the ones where there's true positive lab results, and then the gray shaded ones are where we have false positive lab results. So you can see that if the clinical diagnosis is coded about a day or two before the lab test is performed, there's a much higher risk of it being a false positive. So we're seeing patient in clinic, they present with clinical symptoms, we're going ahead and diagnosing them with the disease, and then we're doing the laboratory testing, but it turns out that it's negative. If we look at those who actually have a more specific ICD code for chlamydia, you can see that the true positives now, again, are at same day of the laboratory test, a day later, 2 days later, 2 to 5 days later, and so on and so forth. So if we're giving the ICD-10 diagnosis after the lab test is done or concurrently with the lab test, we're more confident that it is a true case of disease rather than the false positive, which again tend to happen either way before, like a couple days before the lab test is done, or if there's no lab test at all. So we conclude from doing this that ICD-10 codes are accurate for chlamydia and gonorrhea, not as accurate for syphilis, and there's low sensitivity, suggesting that there's really, if we look only at claims sources like Market Scan, we're going to underestimate significantly disease incidence and burden in a population. Clinician behavior suggests that many clinicians prefer to use this unspecified STD code and give that before they do the laboratory testing. Therefore, we may want to be skeptical about including those in our case definitions when we're going to do research or in public health practice. So following on this study, the CDC then asked us to look at STI testing specifically in pregnancy. So CDC has guidelines that say testing should occur during the first prenatal visit, which is should be for patients who are under 25 or those who are at high risk for chlamydia, not high risk pregnancy, which if you're older than 25. And that you should also, for those who are high risk of contracting an STI, do testing again in the third trimester. Okay, and that's for both chlamydia, gonorrhea, and syphilis, as well as some other STIs. And then CDC recommends also testing in cases where the pregnancy ends in a stillbirth, doing the testing again after delivery of the fetus. And so miscarriage is up to 20 weeks. Stillbirth is considered 21 weeks and beyond in the United States. In the rest of the world, by the way, it's 28 weeks and beyond. But in the US, we consider from 21 to 28 weeks also a stillbirth, not a miscarriage. So we wanted to kind of focus in on stillbirths because there's a lot of evidence to suggest that untreated syphilis and other STIs can lead to stillborn children or fetuses. Stillbirth in the United States, the only data that we really have from the CDC comes from 2003. We're really behind in public health. But it shows that generally there was a decline in stillbirths for those that are 20 to 27 weeks, kind of flat-ish for those who are 28 weeks or more, between the late 90s, early 2000s, and 2013, and that it really only occurs in 1% of all pregnancies, which is about a rate of 3 per 100,000. However, in Indiana, we have a higher incidence than this. Some of you may remember this news article. There's been a lot of focus in Indiana on infant mortality, and part of what's driving infant mortality are stillbirths. And we have a published reporting rate, a published rate of 4 per 100,000, compared to, again, about 3 at the national level in 2013, and that results in about 1,000 fetal deaths. Indiana, of course, ranks very low in public health across the board. We're 43rd in women's health, and we're 49th for public health funding. So that presents some challenges in our state when we're trying to tackle maternal and child health issues. The other thing that's important that I want to point out and why we care about stillbirth is that this is a huge area for healthcare disparities. So if we look here, there's about 10 deaths per 100,000 for non-Hispanic Blacks versus non-Hispanic whites. And so this is a problem that we need to address to bring equity in maternal child health, particularly during pregnancy. So to look at stillbirths, we use the IMPC again in women who had a pregnancy between 2010 and 2016, including those who had multiple births. This time, since we were including that span of when ICD-10 was implemented, we included ICD-9 and ICD-10 codes. So there's the list of them there. And then, of course, we linked the stillbirth cases to encounter and laboratory testing data to confirm those cases that were positive for an STI. So were women with a stillbirth deliveries tested for syphilis, right? Was our main question. And so we wanted to look at the laboratory test result, confirmatory test with the result, or in some cases where we had CPT codes, we wanted to look at a CPT code that documented that testing was performed, because our main outcome was not necessarily whether someone was positive for the disease, but did they get tested, which is the guideline from CDC. Also, testing could occur during pregnancy, so we had a window of saying, okay, from the date of the stillbirth delivery, we look 270 days backwards as a proxy for, because we don't always have a positive pregnancy test in the IMPC. Also, we wanted to look 30 days after pregnancy because, again, the test should have occurred sometime shortly after the delivery of the fetus. Here is what stillbirth cases look like along with testing during this time frame. So remember, at the national level, we only have data through 2013 where it shows a decline. We see significant increases in stillbirths after 2013, particularly for Indiana. And that testing is, you see that the orange line is not on top of the blue line. So testing is not always occurring during pregnancy like it should. So we found about 4,300 stillbirth deliveries among 4,300 women during this sort of 7-year time frame. During the same time frame, there were nearly 600,000 births in the state of Indiana, which means we have a rate of 7.4 stillbirths per 100,000. So this is twice the national average, not just one more per 100,000, like what we would see if we look at the data from CDC. And those data, by the way, come from death certificates. So we're accounting for cases where there is no death certificate of the fetus filed. Among stillbirth deliveries, syphilis testing can occur in about 60% of cases. So we could do a lot better to ensure that women are getting tested. And part of that is women who are not getting prenatal care. So stillbirth surveillance challenges for the state. Stillbirths are not reported to public health. As I mentioned, a death certificate is required for the fetal death reporting system, but a lot of times a death certificate is not filled out. Most death certificates also, by the way, lack a real cause of death, which is a problem if you want to study this by looking at the data. And it's often issued before any testing can occur on the fetus. In 2014, then President Obama signed the Sudden Unexpected Death Data Enhancement and Awareness Act, which sort of calls on public health and states to do more to ensure that these deaths are accounted for and reported and documented, but it provided no funding to do this work. And as we all know, unfunded mandates often don't get done. So that led us to what we're currently working on with our registry and the data. So once again, we're looking at pregnancy and syphilis screening. This time we're looking at it in both live births and for those with a stillbirth. And what we're interested in is particularly looking at subpopulations where there's a high-risk pregnancy, and also trends over time, and then the factors that are associated with testing. So we know that testing is only getting done, we think, I should say, in the prior study, we didn't do, we looked at the data from the IMPC, but we didn't do any chart reviews, we didn't do any follow-up. So again, given what we know from our work on the STIs, we need to do some digging to make sure that those rates are true, and that is the true burden in the population. So that's the purpose for this study. So, and we want to not only confirm and validate the coding of the ICD for stillbirth, but we also want to look at the factors that are associated with testing. So what might drive someone to get testing? Again, we hypothesize it's based on those who have prenatal care. We hypothesize it may be driven by other factors, but we want to confirm those through a more detailed study. And then we want to look at the proportion of stillbirths that do actually have fetal autopsies, exams, genetic testing, and placental exam, which are also supposed to be done as part of the delivery of the fetus. So once again, we're using retrospective data in the IMPC. This time we're looking at a 3-year time window to make our lives a little bit easier. And we're augmenting what's in the IMPC with the EDW, which comes from Eskenazi, and the IU Health Data Warehouse. So that some of the newer, more detailed data sources we have access to in the data core. And in addition to ICD codes for stillbirth, we're also identifying cases this time using in-depth and text mining. And so we hypothesize we may be able to find more cases of stillbirth than what we even found from just looking at ICD codes, which all of you should be like, oh my God, that's scary, because that means it's happening even more than what is reported and what we think might be going on. And then we want to compare that NOP process to our ICD-only approach. What we want to collect are the demographics on each of the mothers, their co-infection with CTGC, which is chlamydia, gonorrhea, and or HIV. So we want to look at those who are particularly positive for STIs versus not. Again, there's a lot of testing that goes on in pregnancy. Most of it is negative, thankfully. Comorbid conditions as well, looking at diabetes and other chronic conditions like kidney disease. We want to look at their history of pregnancies. So get the number of previous pregnancies they have. Do they have a history of stillborn children? Behavioral data looking at smoking, tobacco, alcohol, genetic testing if it's done, fetal heartbeat, and we want to actually confirm some things around the stillbirth, like to be officially a case of it, it really needs to be sort of, unfortunately, the fetus needs to be dead when it's delivered, not that it lives for a few minutes and then dies, which counts towards infant mortality, but doesn't really count as a stillbirth. And then we want to look at cause of death and the placental exam results and the autopsy results to give some detail there in what we find. So preliminary counts, we had about 34,000 live deliveries. So this is linking the Marion County Birth Registry to the IMPC, and it was a pretty good match rate. So thank you, Andrea. And so we've got a lot of live deliveries that we can look at, and we can look at those who are tested for syphilis. And again, we need to confirm some of these numbers, but it looks like the majority of them are tested for syphilis and very few are positive, thankfully, for syphilis. So we're always concerned about congenital syphilis. The preliminary counts on the stillbirth side, we identified about 2,000 codes during the 3-year time frame from the ICD codes and an equal number from in-depth notes, and interestingly, the overlap is only 261. So this is a little scary. So we definitely want to confirm that all these things that we find through in-depth are accurate, because if they are, this is a game changer for how we might report for public health going forward. So in terms of syphilis testing, for ICD codes only for stillbirth, not as many are tested for syphilis. So right away, there seems to be a difference between stillborn deliveries and testing for syphilis versus live deliveries and testing for syphilis. And it's actually higher in the in-depth notes cohort, at least based on the preliminary numbers, which again is interesting. So after we do some of our validation work, we'll see if those numbers hold true. And again, positivity is very, very tiny. So less than 20 cases in the two groups, so it's less than 10 in each group, so I don't know the actual approximate number, but again, small percentage, which is actually what we would like to see, because we don't want to see very much positivity. So where are we at with this? We've gotten the preliminary counts from Andrea/DataCore, so thank you again. Our protocol for our chart reviewers, which is also is based on our previous work, then we expanded it out. That is done and ready to go. So we're kind of struggling one question, and this is where I would invite those of you to participate in today's discussion, particularly give me feedback on how many charts should we review, because we can't review all 3,000 charts that we found, half from ICD only, half from in-depth. So we're thinking about right now a 5% sample and asking ourselves, is this sufficient for doing the validation work to determine is this a true case of stillbirth, and was there any kind of syphilis testing done or STI testing done as part of that pregnancy. And then we've got, again, ICD only versus in-depth, and then we are planning to review all of the positive syphilis cases, because we, again, want to do staging of syphilis in addition to asking these questions around the validity of ICD codes. So our next steps are to do the chart reviews once we confirm our numbers and line everything up with the chart reviewers, validate then the ICD codes, the in-depth classification of stillbirth and testing, and then calculate, then once we have the real numbers, we can calculate the rates of stillbirth for the state and syphilis testing. We can also look at looking at those factors that contribute to the testing by using regression models to examine those that are associated with getting a test or not getting a test, as the case may be, in both live births and stillbirths, which we think may be different. So I'd like to acknowledge, I mentioned that we have some really critical partners. That includes Dr. Janet Arno, who runs the Bellflower Clinic and is at the Marion County Public Health Department, along with Shane Hanley, who's a graduate of our school and now works for Janet. Jane Wang did a lot of this work before Andrea came on board, so we certainly want to recognize her. Andrea is now carrying the torch forward. Ashley, who's our amazing project manager. Sarber Herkar, who just left us to go to Ohio State to become an assistant professor. So we're very happy for him, but sorry to see him go. Yinling and Opie are some of our postdoc or pre-doctoral fellows in our training program here at Regenstrief, and then our two scientists at CDC, Dr. Tao and Dr. Patel, who are great partners to have. Speaking of the training program, we have this wonderful program that brings us students like Opie and Yinling. We're funded by NLM through 2022, and the funds support the training of these folks and engaging them in our research. And our goal is to produce public health informatics researchers, and we're currently looking for another postdoc fellow. So if you know of anybody, please forward them my way. The research that I talked about today is part of our larger program in public health informatics at the Regenstrief Institute, where we're trying to support and improve the business of public health, which includes surveillance of disease and the burden of disease, assess and improve the health of populations, and of course, educate and train the next generation of public health informatics researchers. With that, I am done and welcome your questions and comments. Thank you. Blaine?
Great talk as usual, Brian. Formal comorbidities, blah blah blah. Are you guys looking at mental health? Patients with mental health problems?
I don't think that's one of the things we're specifically looking at, but we may be able to document that as part of the chart review.
Yeah.
Those are not, it's not typically associated with sort of the known risk factors for STIs, but we could sort of.
No, I was thinking about, in terms of infant mortality more.
Oh, infant mortality. I see. Yeah. No, I don't think it's particularly on the list because we were interested in those things that would probably be associated with, either stillbirth, are known to be associated with stillbirth or STI infection during pregnancy. Yeah.
Well, you talk about disparities, right?
Yeah.
It's a huge population of folks that there's probably disparities that exist.
Okay. Good suggestion. Yes, Steve.
I agree. Really nice talk. Very thought-provoking. You presented something that really startled me, which was the difference between your NLP discovered cohort and your ICD discovered cohort. If I did my back of the envelope right, it's less than a 10% overlap between those two. And that begs explanation. It's almost inconceivable to me that an ICD code shows up for a stillbirth and NLP can't find that. And honestly, vice versa. So how do you have some preliminary hypotheses as to how that comes about?
Yeah, we're just now starting to look into that. I think that, I personally hypothesize that some of the positive screens from in-depth that don't have an associated ICD code are because of some standard question. It might be documented about some prior stillbirth, not the current pregnancy. So I think there may be in the documentation, we know, for example, one of the sets of notes that we had to throw out from even considering are sort of initial sort of OB admission notes, because there's a standard questionnaire that says, have you ever had like a stillbirth delivery, right? So it's picking up on that. So we threw those out because we're trying to improve, the performance of the algorithm. But I still think there's some of those in there. That's my hypothesis, and that's what we'll find out. So I think that some of those are red herrings right now because they're referring to some past event. But otherwise, I was surprised that the overlap was so small, because I would think that if you got a diagnosis of stillbirth in the record, it's because that there was some kind of fetal exam or autopsy that was performed. We're seeing we actually see more headers and in-depth for autopsies, but then they end up being like, C chart. The text just says C chart. So NLP is not picking up on those, but there clearly some fetal autopsies are being done. They're just not the actual pathologist notes are not in the text where we can mine it. So I think there's some of that, which is why we see so many ICD positives without any kind of corollary evidence that we can mine from in-depth. But and I think on the other side, there's more red herrings that we need to filter out. But beyond that, I don't know, and I'm interested to learn.
And in your planned gold standard chart review, are you including some documentation about pulse or lack of pulse at the time of birth? Because that is the distinction between an infant mortality and a stillbirth, right?
Yes, those questions around pulse or heartbeat are definitely part of what the chart reviewers will be looking for as they cull through the documentation. Yeah. Oh, Kurt and then Blaine. Oh.
Steve, you probably know when John Duke was here, the same thing was found around prostate cancer, right? ICD terms for diagnosis of prostate cancer were far below NLP evaluation of pathology reports. So you wonder how many, conditions, states this extends to.
Yeah, well, I frequently quote my own informal review looking at ICD. Now, this is older, ICD-9. I don't think what I said then is probably still true, but maybe. I found when I did sort of an informal review of articles that had looked at ICD coding versus chart review, that there was about a 30% error rate going both ways. And it was actually fairly consistent. I had been kind of hoping that in the era of EHRs where, systems can suggest ICD codes so that you're less likely to code based on whatever's on the piece of paper in front of you, that maybe they were getting more accurate.
Well, unfortunately, actually, we've not seen the accuracy. So the first study that I talked about, when we find these, clinicians seem to like this unspecified STD code of A64. So I remember when we switched over to ICD-10, the clinicians were asking us for, the top 20 codes that they could just put in their pocket and keep with them, right? And so we're getting, generic diabetes or generic heart disease or whatever, instead of getting the more, with ICD-10, you have a lot more granularity you could have in the note, or I'm sorry, in the system, but we're not seeing it. There's this strong preference to just go with a generic one, especially in those cases where they haven't done the testing yet. And so as opposed to at ICD-9, people were more likely to use the more specific chlamydia or gonorrhea code. So, yeah.
Two questions related to STD issue. One, the fact that you only had a 10% sensitivity of ICD codes, which means most of the positive, 90% of the cultures were not getting coded. And so my question there is, lab tests often come back a day or two after a visit. So if I'm a clinician, I'm going to code that visit. I'm unlikely to be recode 2 days later, and in fact, I don't know if it's possible, when a lab test comes back. So I'll deal with the lab tests, but I'm not necessarily, I might write a prescription, but I'm not going to go in and do a code. Do you think that's part of the problem? The lag between when you code a visit and then the lab test comes back 2 days later?
Yeah, I do think that's part of the problem. And so I think it's an issue if you're going to look at claims only for diagnoses to, like if you're going to use some system like Market Scan and that's going to be your only source to find cases, you're probably going to miss a bunch of cases. And part of that is the workflow, because you send the lab test out, it gets done 24 to 48 hours later, and you get the results back. And yeah, you as the clinic, your clinic reaches out to the person and gives them the lab results, but you don't go back and update the chart with a new ICD code.
The other thing I was more surprised about is when there's an ICD diagnosis, let's say a false positive diagnosis, like you're seeing, they code chlamydia or gonorrhea. And which is interesting because that's a stigmatizing code. It's a reportable disease.
Right.
And I wonder why that is, why they're actually coding something without a lab test as a sexually transmitted code. I wonder if part of the problem there is, because I had the problem in the VA, it's really hard to find codes for things like discharge and dysuria. I searched and I couldn't find, they wouldn't let me put it in. I was forced to put more of a disease-based diagnosis. So sometimes this box we're forced into forces us to code diagnoses, and it makes it hard to code symptoms.
Right. That's a good point. Other questions or comments? Nope. I see one brewing and see you.
You asked about how many charts to review.
Yes.
It's not that simple.
Wow. I knew you were going to say that.
You need to optimize your sampling to get the most information for the number of charts reviewed. So I can talk to you later about that.
Yeah, that'd be good. Yeah, because I fear the number is much higher than what we have the funds to do and the
there
time
are
to do.
a lot of complex statistical issues too. So we probably should have a long talk.
Okay.
Okay.
All right. Oh, down there.
I don't know how to use this. Okay. I don't know if you're looking, but since syphilis was such a small percentage of the cases, with the comorbidity things that you're looking at, have you seen a trend so far in something that's popping out to you as more likely causing the level of stillbirth? Are you seeing something trending in your comorbidity research so far?
Well, we haven't done a chart review, so we don't really have a lot of data yet. But what the variables that we're collecting are things that have been associated in prior studies. Yeah, I think the low numbers of positive syphilis are somewhat surprising to Dr. Arno. Dr. Arno thinks, she has a hypothesis that syphilis is in untreated syphilis in the cases of multiple births is leading to stillbirths, because you could have in a stillbirth situation a non-trivial number of them are cases where there's multiple fetuses and one of them it dies, right? So it's not like these are all single pregnancies that end with a stillbirth. So that there's a hypothesis that STIs might be contributing to fetal loss in multiple birth cases, but that's something that we'll look for as a sort of sub-study of this. But so far, we don't have anything to suggest that certain comorbid conditions are associated with stillbirth more so than others at this point.
It dawned on me, maybe I should say something about the question you actually asked, which was about sample size for your chart review, and I think actually this comment made me think about this. I think it's a fairly straightforward sample size calculation, except I would consider doing a stratified sample, because you may have different behaviors of your both case finding strategies. You may have different behaviors for different STIs. And if you don't stratify your sample, and syphilis is a rare relative to the others, you may not detect that it's different for syphilis, for example, than it is for chlamydia. Syphilis is rarer, more stigmatizing, less, in some cases, less likely to be found, for example. So that's the only thing I would add to that.
All right, thanks, Steve. Other comments or questions? If not, we still are in. Oh, did you have one now? Oh, if not, then we're still ending early. So thank you very much.